Okay guys, so this is the part 2 of our discussion for the lecture part of the liver function. So we still have three major topics to discuss. So first, we'll discuss the bilirubin metabolism, followed by derangements of bilirubin metabolism. When we say derangement, it means there is a disturbance in the operation or function of something. So in here, there is a disturbance in bilirubin metabolism. Okay? And this derangement of bilirubin metabolism, so, under bilirubin metabolism, we will discuss on how bilirubin is made. Okay? So, kung ano nangyayari, bakit nagkakaroon ng bilirubin, where does it come from, and where does it go after its metabolism. Okay, guys, so do not forget to take down notes and please do not forget to submit your outputs. So, this is a bloody discussion for the liver function because you really have to understand the metabolism of bilirubin in order to understand why is it increased in some diseases. Okay? So, anong nangyayari? Bakit kaya tumataas? Bakit si unconjugated or bakit si conjugated naman yung tumataas? Okay? So, bilirubin comes from the RBC destruction. Okay? So guys, we will differentiate the unconjugated and conjugated bilirubin. So sorry, I forgot to remove this during my previous recording. So unconjugated bilirubin, that is also known as the indirect bilirubin, while for the conjugated bilirubin, the other term for that is the direct bilirubin. Take note that the unconjugated, that is insoluble in water. Okay, unlike for the conjugated, which is polar, that is water soluble. Okay, so guys, 200 to 300 milligram of bilirubin is produced per day. Okay, majority of that is removed through the feces, and some are excreted in the urine. And it takes a normally functioning liver to process the bilirubin and to eliminate that in the body. Okay? And the excretion or removal of the bilirubin from the body, it must be first conjugated. Okay? Therefore, the body cannot get rid of the unconjugated form of the bilirubin. Okay? And in a healthy adult, okay, it is a very low level of bilirubin with a reference of 0.2 to 1 milligram per dl in the serum. And of this amount, the majority is the unconjugated type. Bakit kaya yung majority is the unconjugated type? Because the conjugated bilirubin is excreted in. So now we are on the second topic, which is the derangements of bilirubin metabolism. Okay, derangement, or there is a disturbance in bilirubin metabolism. First, we will cover the causes of elevated serum levels of unconjugated bilirubin. And in our discussion, there will be five major, okay, derangement of bilirubin metabolism that would increase. So first on the list for the causes of elevated serum levels of unconjugated bilirubin or the indirect bilirubin, so we have hemolysis. So hemolysis, it results when the increased level of unconjugated bilirubin, okay, due to hemolysis results when the rate of bilirubin formation exceeds the rate of liver clearance, and this occurs in hemolytic anemia. Okay? So, bakit tumataas yung unconjugated? Because there are a lot of heme that is produced. Because of the increased destruction in the red blood cell, increased rate of hemolysis, sobrang daming heme ang nag-accumulate sa katawan natin. So, in that case, if there is a lot of heme, okay, it will be converted to a lot of unconjugated bilirubin. And if there is a lot of unconjugated bilirubin, it will take time for the liver to process it to become conjugated bilirubin. Like for example, kunwari lang, kung si liver kayang mag-process ng 1,000 heme, so this is just an example, we put it in numbers for you to understand it better. So for example, in a day, si liver kaya lang yan mag-process ng 1,000 bilirubin, okay, unconjugated bilirubin to the unconjugated bilirubin to become the conjugated bilirubin. But in cases of increased hemolysis, just like in hemolytic anemia, magkakaroon ka ngayon ng, for example, 100,000 na unconjugated bilirubin. Okay? Because of the increased extraction, sobrang dami ng unconjugated bilirubin mo. So, the liver cannot process those unconjugated bilirubin. Anong mangyayari sa unconjugated bilirubin sa serum mo? Okay? Tataas. It will be increased. Okay? It will be elevated. Okay? So, in hemolytic anemia, unconjugated bilirubin rises as a result of abnormally high level of hemoglobin, okay, released from the erythrocyte. Sobrang dami ng hemoglobin ang na-release because of the RBC destruction. So, in that case, sobrang daming hemoglobin ang mabibreak into heme, globin, and iron. So, sobrang daming heme that will be converted into bilirubin, okay, and will be further converted to become the unconjugated. So, anong mangyayari? Magpa-pile up yung unconjugated bilirubin. So, that would reflect in the rise, okay, or that would be seen in the serum. Okay? Kasi hindi naman siya ma-release. Okay? Hindi siya mako-convert agad-agad, lahat-lahat ng liver. So, if the rate of bilirubin formation exceeds the rate of liver clearance, okay, just in this case, there is an overproduction of bilirubin, there will be a rise in the bilirubin level in the serum. Okay? So, virtually all of this bilirubin will be the unconjugated type, the unconjugated bilirubin. So, this type, or in this case of increased level of serum unconjugated because of hemolysis, this is particularly seen. It is not common, okay, but it is particularly to occur in neonates, okay, especially if their UDP-GT activity is low, okay. Kasi in neonates, the activity of the UDGPT is lower as compared to us, okay, sa ating mga adults. So, those one manner of confirming a diagnosis of hemolytic anemia is the finding of increased level of unconjugated or the indirect bilirubin that is found in the serum. Okay? So, kapag nagkakaroon ng hemolysis, ano yung magiging level ng unconjugated bilirubin? That is increased. Okay, so second cause of elevated serum level of unconjugated bilirubin, that is ineffective erythropoiesis. So, in ineffective erythropoiesis, small amounts of hemoglobin may be lost at the time of nuclear extrusion, just like in example. So, we have thalassemia major. So, a little bit discussion of your thalassemia. So, in thalassemia, okay, so we're now in the third cause of elevated serum for unconjugated or indirect bilirubin. So we have the Gilbert syndrome. The Gilbert syndrome that is characterized by mild hyperbilirubinemia. So it is just mild, hindi sobrang taas ng level ng unconjugated bilirubin. Okay? So mild lang siya. The most common cause of the Gilbert syndrome is jaundice. Okay, so we'll discuss further jaundice, okay, in the later part of our discussion. So the pathogenesis for the Gilbert syndrome is there is an insertion of the two bases into the promoter region of the UGT1A1 gene, which is a part or which is a gene that is a part of the UDGPT. Okay? So, what else? A more severe form of the Gilbert syndrome, that is the Crigler-Najjar syndrome. Okay? So, for both the Gilbert syndrome and the Crigler-Najjar, the problem rise from the genetic mutation in the UGT1A1 gene. Okay? So, ang nagiging problema in Gilbert's and in Crigler-Najjar is actually the enzyme UDGPT. Okay? And what is the function again of the UDGPT? It is the enzyme that catalyzes the enzymatic reaction for the conversion of unconjugated bilirubin to conjugated bilirubin. So, the Gilbert syndrome that is characterized by intermittent unconjugated hyperbilirubinemia, underlying liver disease due to a defective conjugation system in the absence of hemolysis. So, the hyperbilirubinemia usually manifests during adolescence or early childhood. The total serum bilirubin usually fluctuates between 1 to 3. Okay? Okay, so we're now on the fourth causes of elevated serum level for unconjugated bilirubin. That is the Crigler-Najjar syndrome. The Crigler-Najjar syndrome, that is a syndrome of chronic non-hemolytic unconjugated hyperbilirubinemia. Okay, so for both Gilbert syndrome and Crigler-Najjar, walang hemolysis na nangyayari. Okay, kasi ang problema kay Gilbert at kay Crigler are the enzymes, okay, that catalyzes the conversion of unconjugated to conjugated. Okay? So if that is the case, if the enzyme, guys, take note of this one, if the enzyme that is catalyzing the chemical reaction or an enzymatic reaction is not functioning properly, okay, the what do you call this one? The reactant will not be converted to become the product. So, anong mangyayari? Puro reactant na lang ang nangyayari. So, if you can imagine, meron kang reactant, meron kang enzyme, meron kang product. If the enzyme is not functioning properly, anong mag-accumulate? Yung reactant yung mag-accumulate. That's why there is an increased level of unconjugated bilirubin, okay, in the Crigler-Najjar and the Gilbert, kahit walang hemolysis. Okay? Kasi, normally, meron pa rin namang heme na napoproduce because of the destruction of the old red blood cell. Okay? So, ano nangyayari? Kumbaga, napapile up. Okay? Napapile up yung level ng unconjugated na hindi siya nakakonvert into the conjugated type, kaya tumataas yung level niya. Okay? So, the Crigler-Najjar syndrome that is subdivided into two types, the type 1 and the type 2. Okay? Mas malala yung type 1, it is more severe, the type 1 is more severe as compared to the type 2. Okay? So, for the Crigler-Najjar syndrome type 1, that is characterized by striking unconjugated hyperbilirubinemia of about 20 to 40 milligram per dl. Okay? So, imagine 20 to 45 milligram. Okay? That is very high. Hyperbilirubinemia. Okay? That appears in the neonatal period and persists for life. So, it persists for life. So, most likely, if you have this high level, okay, it is very visible that you will have a jaundice. Okay? Magkakaroon ka ng yellowing of the skin and other parts of your body. Possible also magkaroon ng kernicterus. So, pathogenesis. Pathogenesis for the Crigler-Najjar, I'm so sorry, is multiple mutation in the UGT1A1 gene, including shifts in the reading frame, stop codons, and critical amino acid substitution. Unlike kay Gilbert syndrome, okay, anong nangyayari doon? Nagkakaroon lang siya ng reduction of the activity of the UDGPT. Okay? Nagkakaroon ng lower enzymatic level. Okay, as compared to the normal one. So, meron pa rin nako-convert. Okay? Definitely may mako-convert pa rin, but nagkakaroon lang ng lower activity. In Crigler-Najjar Syndrome, mas malala yung problema niya kay UDGPT because of multiple problems on the genes of that enzyme. So, the pattern of inheritance, that is autosomal recessive. So, under type 1 of Crigler-Najjar, so the unconjugated hyperbilirubinemia becomes marked. Okay? Take note of this one. In Crigler-Najjar syndrome, the unconjugated bilirubin is almost always exceeding 5 milligram per dl. Okay? So, and causing jaundice. Okay? And sometimes it exceeds 20. Okay? So, it's like here, 20 to 45 milligram per dl. Okay? Hindi na siya bumababa sa 5. And sometimes, yun nga, more than 20 pa siya. Affected infants develop severe unconjugated hyperbilirubinemia. Okay, again, Gilbert syndrome, Crigler-Najjar, and the Lucey-Driscoll syndrome, increase in unconjugated. So, magkakaroon na ng hyperbilirubinemia. The type is unconjugated hyperbilirubinemia. Okay? So, this one leads to kernicterus. Okay? Kernicterus. So, there is a kernicterus or the deposition of bilirubin in the brain. Okay? Particularly affecting the basal ganglia, mainly the lenticular nucleus, causing severe motor dysfunction and retardation. So, among the different causes of elevated serum level, ito na yung pinakamalala. Okay? Why? Because it can lead to severe motor dysfunction and retardation. And what is the main cause, guys, of the possible retardation of an individual? It's because of multiple mutation of the gene that is causing the conjugation of the unconjugated to the conjugated bilirubin. And that enzyme is the, okay, what is that? The UDGPT. And the UDGPT stands for what? That is uridyl diphosphate glucuronyl transferase. Okay. So, we proceed with Crigler-Najjar type 2. So, this is a less severe form of the Crigler-Najjar. Okay, the enzyme activity is approximately 10% of normal. Okay, and survival to adulthood is possible. Maybe for the Crigler-Najjar type 1, it's very rare for an individual who is born with type 1 to live until adulthood. Okay, but for type 2, okay, it is possible to survive until the adulthood. So the danger of kernicterus is uncertainty at levels exceeding 20 milligram per dl. So it is vital to treat these infants with phototherapy. Why phototherapy, guys? Okay? In your clinical chemistry 1, if you remember, kung naalala nyo lang naman, di ba? Bilirubin is sensitive to light. Okay? It is deactivated by light. Okay? So, that is the method for treatment of high level of bilirubin, that is exposing the individual into a high level of light. Okay? Phototherapy. Okay? To cause the excretion, and the purpose of that, the phototherapy, is to cause the excretion of the unconjugated bilirubin. So, for some parents, I don't know if you have noticed this, but certainly for me, yes. When a baby is born, okay, sabi nila, ibilad mo daw sa araw. Okay? Aside from the vitamin that can be, of course, the sun will not give you the vitamin, but it will cause the activation of the vitamin D that's present in the skin. Okay, aside from that, pag sinasabing nag-yellow yung bata, okay, ibabad mo daw sa araw. Okay? So, when I was reviewing medtech, I saw the logic behind that. Okay? So, kapag nag-yellow kasi, possible nagkakaroon ng jaundice because of an increased level of bilirubin. Okay? And exposing bilirubin to light would lead to the destruction and possible na ma-eliminate siya. Kaya yun din yung ginagamit na principle sa phototherapy of the of individuals with high levels of bilirubin in their serum. Okay, so we're done with this one. We already discussed this in Crigler-Najjar type 2. DUGT1A1 in liver is usually present, but that is less than 10% of the normal. And hyperbilirubinemia was not recognized in some cases until later in life. Okay, so we have here principal differential characteristic of Gilbert and Crigler-Najjar syndrome. So among the three guys, which is the most severe among the three, type 1, type 2, or Gilbert syndrome? Let's just assess your learning. Okay, 1, 2, 3. It's the type 1 Crigler-Najjar syndrome because it can exceed, okay, it can exceed 20 milligram per DL. Okay, unlike for the 2. But sometimes even for the type 2 of Crigler-Najjar, it can also exceed the 20. Okay, but as you can see here, guys, for the total serum bilirubin, that is usually greater than 20 for type 1, less than 20 for type 2. Okay, unlike for in Gilbert syndrome, it does not even exceed 4.5 milligram. Okay, so routine liver tests, they will be normal. Okay, but for bilirubin, the bilirubin would reflect an increased level. So connectorus, that is usual for type 1. That is also possible for type 2, but it's very rare and not in the Gilbert syndrome. Why? Because the connectorus, that is, it can most likely happen if the level of the bilirubin is greater than 20 milligram per DL, which is common for the type 1 Crigler-Najjar syndrome. Okay, so what else? So that's it for this. So last cause for the elevated serum level of unconjugated bilirubin in our discussion is the Lucey-Driscoll syndrome. Okay, so in the Lucey-Driscoll syndrome, the problem lies with an antibody that is acting against the enzyme, the UDPGT. Parang sinasabi ko kanina, UDGPT. Okay? I'm sorry, it should be UDPGT. Okay, ang haba-haba. Or uridyl, okay, diphosphate glucuronyl transferase. So in the Lucey-Driscoll syndrome, there is an antibody acting against the enzyme. So kung merong antibody dyan na nag-act dun sa enzyme mo, okay, there is a possibility that the conversion of the unconjugated bilirubin to conjugated bilirubin will also be lower as compared if you don't have that antibody. Okay, ganun din yung nangyayari sa diabetes. If you remember, okay? If you remember, is it type 1 or type 2, yung may antibody? Okay, I hope you can remember that. The presence of the antibody in diabetes, is it type 1 or type 2, guys? Okay, so isasama ko yan sa quiz nyo. Kasi discuss nyo naman na yan sa CC1. Okay, I hope you can remember. Okay, so last part of our topic. I hope you are all well. No, hindi pa pala to last kasi part pa lang siya ng derangement of bilirubin metabolism. Okay? But tapos na tayo dun sa causes of elevated serum level of unconjugated. Now we proceed to elevated causes of elevated serum levels of the conjugated bilirubin. Okay, ito yung tapos na siyang i-process ng UDPGT, na-convert na siya from unconjugated to conjugated. Okay, so we have, in our discussion, we will have three. Okay, so first cause of elevated serum level of conjugated. Okay, so guys, wait lang, i-review natin. What are the causes of elevated serum level of unconjugated bilirubin that we have discussed already? Okay, number one, ano yung one natin? So, I'm pausing a bit after the number for you to remember it on your own. Okay? Parang review nyo na rin. So, one, we have hemolysis. Second, ineffective erythropoiesis. Third, Gilbert syndrome. Fourth, Crigler-Najjar syndrome. We have type 1 and type 2. What is the more severe? Type 1. Which usually cause kernicterus? Type 1. Okay? And the last one, that is the Lucey-Driscoll syndrome. Okay, now we go to the causes of elevated conjugated bilirubin. Okay, first we have the Dubin-Johnson syndrome. Okay, the Dubin-Johnson syndrome is characterized by a low-grade, predominantly conjugated hyperbilirubinemia. Okay, low-grade siya, low-grade, hindi siya sobrang taas. Conjugated, a high level of bilirubin caused by the conjugated form, not the unconjugated one. So, pathogenesis, defective expression of MRP2, okay, and the pattern of inheritance, that is autosomal recessive. The cardinal feature of this Dubin-Johnson is the accumulation in the lysosomes of centrilobular hepatocytes of dark coarsely granular pigment. Okay? So, Dubin-Johnson syndrome is associated with increased plasma conjugated bilirubin, typically with mild jaundice. Okay? So, nagkakaroon ng mild jaundice with a total bilirubin of 2 to 5 mg per dl. Okay? 2 to 5 mg sa Dubin-Johnson. And biopsy reveals an intense dark pigmentation of the liver due to the accumulation of lipofuscin pigment. Okay, nagkakaroon ng accumulation of lipofuscin pigment. Thus, conjugated bilirubin accumulates within the hepatocytes and eventually back diffuses into the circulation where it is detected in the serum. Okay? Sometimes the Dubin-Johnson can be confused with the Reuter syndrome, possibly of viral origin. Okay, so now we go to we have the Reuter syndrome. So the Reuter syndrome, this benign autosomal recessive disorder, is clinically similar to Dubin-Johnson syndrome, but this is less frequently seen. Okay, a major phenotypic difference is that the liver in patients with Reuter syndrome has no increased pigmentation and appears totally normal. So that is their major phenotypic difference. Okay. So the only abnormality in the routine laboratory test in the Reuter syndrome is an elevation of the total serum bilirubin due to a predominant rise in the conjugated bilirubin. Okay, so unlike for the Dubin-Johnson, the biopsy of the liver would reveal dark pigmentation, but that's not present in the Reuter syndrome. Okay, so biliary obstruction. Now we go to the third cause of elevated serum level of conjugated bilirubin, that is biliary obstruction. Okay, so this condition results from the presence of bile stones, most commonly in the common bile duct, and that is termed as the cholelithiasis. Okay, biliary obstruction due to cholelithiasis results in elevation of total bilirubin, with over 90% being direct bilirubin or the conjugated type of bilirubin. Okay, guys, in adults, do you consider yourself adult already? Cholelithiasis is the most common cause of hyperbilirubinemia. Okay, so this is the most common. Okay, liver function alterations during a disease. So we have first on the list, jaundice or icterus. Okay, so jaundice or icterus is the yellow discoloration of the skin, eyes, and mucous membrane, which usually results from the retention of bilirubin or other substances, and that is classified on site of the disorder. So there are three classifications. We have the pre-hepatic jaundice, hepatic jaundice, and the post-hepatic jaundice. Okay, so although the upper limit of normal for total bilirubin is 1 to 1.5 mg per dl, jaundice is usually not noticeable or visible to the naked eye until the bilirubin reach 3 to 5 mg per dl. Okay? So, the icterus is also a term that is commonly used in clinical laboratories. Okay? So, we use this term when a serum, okay, or plasma has a yellow discoloration due to an elevated bilirubin level. Okay, so pag yellowish because of high bilirubin, uh, that is an icteric sample. Okay, we use the term icteric sample. So, classified based on the site of the disorder, we have the pre-hepatic jaundice. Okay? So, pre-hepatic, ano ang nagkukos ng jaundice? That is before the liver. Okay? So, as you can see from the term, pre-hepatic before the liver. So, bakit tumataas ang bilirubin? Okay? Because of too much destruction of red blood cells. Therefore, in pre-hepatic, ano yung mataas? Is it the conjugated or the unconjugated? Okay, it's the unconjugated bilirubin. Kasi sobrang dami. Okay, an example of jaundice, pre-hepatic jaundice cause is hemolysis. Okay, kasi sobrang dami ng nabibuild up na unconjugated bilirubin. Yung cause ng jaundice mo is before the bilirubin enters the liver. Okay? Kaya siya pre-hepatic. Okay? So, pre-hepatic, the problem occurs before the liver. Okay. So, in pre-hepatic jaundice, it occurs when there is a problem that happens before liver metabolism. So, the liver responds by functioning at maximum capacity. Therefore, people with prehepatic jaundice rarely have bilirubin levels that exceeds 5 mg per dl because the liver is capable of handling the overload. So, the prehepatic jaundice may be referred to as the unconjugated hyperbilirubinemia because the fraction of bilirubin increased in people with prehepatic jaundice is the unconjugated type. Okay? So, si prehepatic jaundice, other term for that is the unconjugated hyperbilirubinemia kasi ang mataas is the unconjugated type. Okay? So, this unconjugated, going back to unconjugated bilirubin, again, that is not water-soluble. Okay? That is not water-soluble and that is not filtered by the kidneys. So, hindi natin yan makikita sa urine kasi nga it is water-insoluble. So, hindi siya magiging soluble sa ating urine. So, we go to the hepatic jaundice. parang dinidiscuss ko naman na siya individually. So, okay, so we're done with this, the prehepatic jaundice. Most common cause is RBC destruction, okay, or hemolysis. And what is increased? Is it the conjugated or unconjugated? Okay, the unconjugated. What is the other term for prehepatic jaundice? That is unconjugated hyperbilirubinemia. Okay, we proceed with the hepatic jaundice. Okay, so for the hepatic jaundice, it occurs when the primary problem causing the jaundice resides in the liver. So, hepatic, nasa liver na yung problema. Si liver na yung problema. Okay? Possible cause, pwedeng intrinsic liver defect, or there is a disease in the liver. So, this intrinsic liver defect or disease can be due to disorders of bilirubin metabolism and transport defects. Okay? So, ano ba yung mga transport defect natin? Transport defects, we have the the Crigler-Najjar, the Dubin-Johnson, and the Gilbert syndrome. Okay? As well as the neonatal physiologic jaundice of the newborn. Okay? Kasi ang nagiging problema doon is the enzyme. Okay? The UDP-GT, UDP-GT, or due to diseases resulting in hepatocellular injury or destruction. So those are the most common causes for hepatic jaundice. Hepatocyte injury caused by viruses, alcohol, parasites, as well as hepatocellular injury or destruction, and transport defects. Gilbert's disease, Crigler-Najjar, and physiological jaundice of the newborn are hepatic causes of jaundice that results in elevation of the, anong tumataas dito? Unconjugated, diba? If you remember, unconjugated si Crigler-Najjar and si Gilbert. But for the Dubin-Johnson, okay, and Rotor syndrome, so both Dubin-Johnson and Rotor syndrome, they also causes hepatic jaundice, but this causes of hepatic jaundice, the fraction of bilirubin that is elevated is the conjugated fraction. Okay? So, conjugated fraction. So, in hepatic jaundice, kanina, in prehepatic jaundice, ano yung tumataas? Si unconjugated or indirect lang. Pero kapag hepatic jaundice, pwedeng mataas ang unconjugated, pwedeng mataas din ang conjugated. Okay, in the post-hepatic jaundice. Okay? Post-hepatic jaundice. Ibig sabihin, the problem occurs after the liver. Okay? So, hindi na si liver. Hindi na si liver ang nagiging problema dito. So, post-hepatic jaundice results from biliary obstructive disease, usually from physical obstructions, like the presence of gallstones or tumors, that prevent the flow of conjugated bilirubin into the bile canaliculi. Okay, so hindi siya nakakalabas ng maayos. Nagkakaroon ng obstruction. Okay? So since the liver is functioning well, ano sa tingin niyo yung mataas dito sa post-hepatic jaundice? Okay, functioning well yung liver. Ibig sabihin, nako-convert niya yung unconjugated bilirubin to conjugated bilirubin. Pero anong meron? Merong obstruction na nangyayari. Kung merong obstruction na nangyayari, hindi ngayon nare-release si conjugated bilirubin. So, kung hindi nare-release si conjugated bilirubin, saan siya mapupunta? Pupunta siya sa circulation. So, anong tataas? Si conjugated or unconjugated? Okay, so si conjugated ang tumataas kapag post-hepatic jaundice. Okay, so in these cases, since bile is not being brought to the intestine, okay, in post-hepatic jaundice because of the obstruction, stool loses its source of normal pigmentation and nagkakaroon siya ng clay na color. Okay? Okay, so first cause of elevated serum level of conjugated. Okay, so guys, wait lang, i-review natin. What are the causes of elevated serum level of unconjugated bilirubin that we have discussed already? Okay, number one, ano yung one natin? So I'm pausing a bit after the number for you to remember it on your own. Okay? Parang review nyo na rin. So, one, we have hemolysis. Second, ineffective erythropoiesis. Third, Gilbert syndrome. Fourth, Crigler-Najjar syndrome. We have type 1 and type 2. What is the more severe? Type 1, which usually cause kernicterus. Type 1. Okay, and the last one, that is the Lucey-Driscoll syndrome. Okay, now we go to the causes of elevated conjugated bilirubin. Okay, first we have the Dubin-Johnson syndrome. Okay, the Dubin-Johnson syndrome is characterized by a low-grade, predominantly conjugated hyperbilirubinemia. Okay, low-grade siya, low-grade, hindi siya sobrang taas. Conjugated, a high level of bilirubin caused by the conjugated form, not the unconjugated one. So, pathogenesis, defective expression of MRP2, okay, and the pattern of inheritance, that is autosomal recessive. The cardinal feature of this Dubin-Johnson is the accumulation in the lysosomes of centrilobular hepatocytes. Okay, so we have here changes in concentration of bilirubin in those with jaundice. I'm so sorry. So most likely, guys, in clinical laboratory, what we measure for the bilirubin concentration is the serum. So if our sample is serum, what tube will you use? Okay, in 3, 2, 1. Is it purple? Is it yellow? Okay, between purple, okay, yellow, and yellow with gel separator and red, ano dun yung pwede nyong gamitin for bilirubin determination in clinical laboratory? Okay, 1, 2, 3. You can use the yellow, okay, the one with the gel separator, or you can also use the red. Okay, so since that is serum, you need a sample without the fibrinogen. Okay, so type of jaundice. We have prehepatic. What is a possible cause for jaundice? For prehepatic, we have RBC destruction or hemolysis. So, ano yung mataas? So, huwag niyo munang tignan dito. Kunwari lang. Okay, kunwari lang. Kunwaring memorize nyo. Okay, in prehepatic, anong tumataas? Mataas ba yung total bilirubin mo? Yes. Bakit mataas? Kasi, ano yung tumataas talaga? Si conjugated or the unconjugated? The unconjugated. Pag prehepatic, mataas ang unconjugated. Pag mataas ang unconjugated, mataas na din ang total bilirubin. Guys, for the computation of total bilirubin, para magets nyo, conjugated bilirubin plus unconjugated bilirubin. So, the value of that is the total bilirubin. So, kahit in the prehepatic, even if the conjugated bilirubin is normal, if abnormally high naman yung unconjugated bilirubin mo, the total bilirubin will be increased. Okay, we go to hepatic causes. Gilbert disease. Ano yung tataas? Unconjugated or conjugated? Unconjugated. Crigler-Najjar, unconjugated. How about Dubin-Johnson? Okay, that is conjugated. Rotor syndrome, conjugated. Okay, so how about the jaundice of the newborn? Unconjugated. Bakit in the jaundice of the newborn, bakit unconjugated? Kasi ang problema nila is the enzyme. Okay? So, hindi nagkakaroon ng magandang conversion of the unconjugated into the conjugated type. So, as you can see, guys, lahat dito, mataas ang bilirubin. Kahit isa lang ang mataas, either the conjugated or the unconjugated ang mataas, tataas ang total bilirubin. Okay? In the post-hepatic, ano yung mga possible causes ng post-hepatic? obstruction pag may mga gallstone or tumor. Okay? So, since okay naman yung functioning ng enzyme, nako-convert naman siya ng maayos, pero hindi siya nare-release, ano yung tumataas? Hindi kasi nare-release tong conjugated bilirubin. Okay? So, guys, as you can see here, mataas din ang unconjugated bilirubin niya. Okay? There are instances wherein mataas ang unconjugated bilirubin and mataas ang conjugated bilirubin. Okay? However, normally, kung okay naman yung liver mo, if the liver is well functioning, the unconjugated bilirubin is within normal limits. Okay? Kasi nako-convert naman siya into the conjugated bilirubin. Ang problema nga lang ay hindi to nare-release. Okay? So, I hope that is clear. So, we go to the next one. We have the liver function and alteration during a disease. Okay? During a disease. So, we have here, if that is, so, tignan nyo dito, hindi siya consistent. Okay? In the prehepatic, mataas ang unconjugated or the indirect. Sa hepatic, hindi rin mataas lahat, ha? Not all hepatic causes would lead to increased level of indirect and direct. Increased level of indirect, ano yung mga possible causes niya? Gilbert's and the Crigler-Najjar. For the direct bilirubin, anong matataas? Anong diseases ang nagkakos na increased level of direct bilirubin in hepatic? The Rotor syndrome and the Dubin-Johnson. In the post-hepatic, okay, in the post-hepatic, eto na, this is not consistent with the table of that was flashed in the last slide kasi pareho silang mataas. Diba? So, pero yung diniscuss natin, if the liver is functioning well, and ang present lang naman are gallstones or tumors, and the enzyme is working properly, the indirect bilirubin are converted into the direct bilirubin. Kaso, merong tumor, so hindi nakakalabas ng maayos sa hepatic circulation, so bumabalik siya sa circulation, kaya tumataas yung conjugated or the direct bilirubin. Okay? So, in the prehepatic, bakit negative for bilirubin ang urine? Okay, bakit negative? Kasi ang problema mo dito is the indirect or the unconjugated. Take note, kahit mataas ang unconjugated or indirect, that is not water-soluble. So, hindi yan ma-release sa bilirubin. Okay? In the hepatic circulation naman, okay? In the hepatic circulation, hindi to consistent, ha? Okay? Hindi to consistent. Hindi laging positive. Hindi laging increase. Kung ang mataas dito ay indirect or unconjugated bilirubin, okay? Negative, and this one is normal. Okay? Kung, like for example, si Crigler-Najjar and Gilbert's, mataas yung indirect pero normal yung direct. So, normal lang din to. However, if the case is increased direct or conjugated bilirubin, tataas din ang urine bilirubin and tataas din ang urine urobilinogen. Okay? So, in the post-hepatic, okay, since increased ang direct bilirubin mo, which is, or the conjugated type, which is, we call this one, which is water-soluble, tataas yung urine bilirubin kasi nga mas maraming masesecrete. Okay? So, for the post-hepatic, depende din. Like, for example, this one, in the urine urobilinogen, okay, pwede kasing hindi siya ma-release because of a blockage. Okay? So, eto, kung may tumor or may blockage, eto kasi, hindi ma-release. Okay? Hindi ma-release yung direct bilirubin into the feces. Hindi siya mako-convert into urobilinogen. Okay? Kasi nga may blockage. Ma'am, pero bakit yung yung urine bilirubin mataas? Okay, kung may tumor or merong gallstone. Kasi nga, take note, the direct bilirubin will go again into the circulation, okay, into the blood. So the blood normally travel or is filtered by the kidneys. Okay, na-filter siya ng kidney. So yung bilirubin that is present in the circulation, okay, or in the blood, can be filtered by the kidney. Kaya lumalabas yung urine bilirubin. Okay? So, ulitin natin, bakit normal ang urine or urine urobilinogen in post-hepatic? It's because of the presence of tumor, okay, and the gallstone. So, from liver, hindi siya mapupunta sa intestine. So, hindi siya makakonvert ng intestinal bacteria to become the urobilin or the urobilinogen. Okay, cirrhosis. Cirrhosis is a condition in which scar tissue replaces a healthy liver tissue. Okay, the scar tissue blocks blood flow and prevents the proper functioning of the liver. Commonly cause of chronic alcoholism, of cirrhosis are chronic alcoholism and hepatitis C infection. Okay? So, take note of this guys, chronic alcoholism. So, yung mga manginginom dyan, matagal nang manginginom, na sobrang dami nang nainom. Okay? So, you should be careful because one of the possible effects of that is cirrhosis and in more severe cases, okay, possible magkaroon ng hepatocellular carcinoma because of chronic alcoholism. Other causes aside from chronic alcoholism, of course, we have hepatitis B infection, hepatitis C infection, and hepatitis D, autoimmune hepatitis, inherited disorders, non-alcoholic steatohepatitis, black bile ducts, drugs, toxins, and infections. Okay, so next we have tumors. So 90 to 95% of hepatic malignancies are metastatic, meaning the cells, the cancer cells are from other sources, okay? So it is not originating in the liver. The cancer cells metastasize into the liver, okay? So we have two types. In general, we have two types of cancer, right? We have benign and malignant, okay? So severe kapag malignant, okay? An example of benign tumor is we have the hepatocellular adenoma and hemangiomas. For the malignant, we have the hepatocellular carcinoma and hepatocarcinoma and as well as hepatoma. Bakit puro hepa-hepa? Okay? So, when you say hepa kasi, it refers to the liver. Okay? It refers to the liver. So, cancers, what do you call this one? Cancers of the liver, metastatic cancer, okay, most of them come from organs, the colon, the lung, or the breast. Okay, so yung mga colon, lung, and breast cancer, they can metastasize to cause a tumor in the liver. Okay. Malignant tumors, so we have there the hepatocellular carcinoma. The hepatocellular carcinoma pala, other name niya yan, yung hepatocarcinoma and hepatoma. Okay, that should be slash. Okay, so other term for hepatocellular carcinoma. So the hepatocellular carcinoma is the most common malignant tumor, okay, of the liver. And 80% of the cases worldwide of the hepatocellular carcinoma are attributed to hepatitis B and hepatitis C infection. So guys, be aware, okay? So take note, hepatitis B, the mode of transmission is through sexual contact with an infected individual. So please choose wisely, okay? Huwag puro puso. Galingan yung mamili. Baka kasi magka-STD kayo. Okay? Ka-STD ka na nga, magkaka-cancer ka pa. Diba? So please be careful. Okay, Reye syndrome. So the Reye syndrome, that is a group of disorders caused by infectious, metabolic, toxic, or drug-induced disease that is found predominantly in children, but there are reported cases also of Reye syndrome in adults. Okay, although the precise cause of this syndrome is unknown, it is often preceded by a viral syndrome such as infection of varicella, gastroenteritis, upper respiratory tract infection caused by influenza. Okay, so although the precise cause of Reye syndrome is not well established, studies have demonstrated a strong epidemiologic association between the ingestion of aspirin during a viral syndrome and the subsequent development of Reye syndrome. So there is a possibility based on a strong epidemiological association that the aspirin, okay, may lead to Reye syndrome. Okay? So the Center for Disease Control, because of that, the CDC cautioned physicians as well as parents to avoid salicylate, just like the aspirin, um, usage in children that are infected with viruses. Okay, so Reye syndrome is an acute illness which is characterized by non-inflammatory encephalopathy, fatty degeneration of the liver, with a clinical presentation of profuse vomiting accompanied with a varying degrees of neurologic impairment such as fluctuating personality, so nagkakaroon ng fluctuating personality changes, and deterioration in the consciousness of the individual. The degeneration of the liver is characterized by, take note of this one, in Reye syndrome, nagkakaroon ng mild hyperbilirubinemia. Okay? Another is 3 times or threefold increase in the ammonia level. Okay? And the aminotransferases, 3 times yung increase niya from the reference range. Ammonia and the aminotransferase, both the AST, the aspartate aminotransferase, and the alanine aminotransferase. So, tumataas yung AST, tumataas din yung ELT, tumataas yung ammonia, tumataas ang bilirubin. So, without treatment of the Reye syndrome, rapid deterioration may occur and it can possibly lead to the death of the individual. So, nakakamatay siya. Okay, last na guys. So we have the drug and alcohol related disorders. So drug-induced liver disease accounts for 1/3 to 1/2 of all the reported cases of acute liver failure in the United States. So the most common mechanism of injury is adverse immune response to drug directed against the liver. Okay, so ba yung mga manginginom ng sobra. Okay, so the liver is the primary target organ for the adverse drug reaction, okay, of the alcohol or even drugs, and it plays a central role in the drug metabolism. So if you remember the detoxification, and the most common mechanism, yun nga, of injury is adverse immune response to drug. Okay, that is directed against the liver. So in this type of mechanism, the drug induces an adverse immune response directed against the liver itself and result in hepatic or cholestatic disease. Okay, so of all the drugs associated with hepatic toxicity, the most important is ethanol. Okay, ethanol, which is the alcohol that is mixed or that is used to make the drinking alcohols. Okay, so mga drinking alcohol yung mga iniinom natin, yung mga naiinom. Okay, in a very small amounts, ethanol causes very mild, transient, and unnoticed injury to liver. However, with heavier and prolonged consumption, it can lead to alcoholic cirrhosis. Okay, kaya kung sobra yung pag-inom nyo, ng mga magulang nyo, okay, so might as well, um, tell them the possible uh, results, okay, or possible cases which may happen to their liver. Okay, so another is, since we are here, drug and alcohol related disorder. I was not able to put it in the PowerPoint presentation. One of the most common drugs associated with serious hepatic injury is the acetaminophen. Okay, the acetaminophen. When acetaminophen is taken in massive doses, it is virtually certain to produce fatal hepatic necrosis unless rapid treatment is initiated. Okay, even for our painkillers, okay, yung mga biogesic, okay, Advil, for the painkillers, take note of the dosage, guys. Diba, every 4 hours yung sinasabi. So, wag niyong sobrahan dun. Okay? Because it really affects the liver. So, that's all for our topic. This part 2 is, it has consumed us 1 hour. Guys, I'm so sorry. We still have this last slide. I'm really sorry. But we really have to finish this one. Last naman na, guys. So, kayang-kaya natin to. So, there are 3 stages of liver injury due to excessive alcohol consumption. We have the alcoholic fatty liver, the alcoholic hepatitis, and the alcoholic cirrhosis. The alcoholic fatty liver, that is mild, and recovery happens with the removal of drug or when you stop consuming alcohol. Okay? So, the alcoholic fatty liver represents the mildest category where very few changes in the liver function are measurable Okay? Take note of this, guys, on the results of the laboratory. Okay? The alcoholic fatty liver is characterized by slight. Okay? Nagkakaroon ng slight elevation in the AST, ALT, and the gamma-glutamyl transferases. Okay? Mild lang. And on biopsy, fatty infiltrates are noted. Okay? Fatty infiltrates are noted in the biopsy for the alcoholic fatty liver. This stage tends to affect young to middle-aged people with a history of moderate alcohol consumption. So kapag moderate pa lang yung consumption mo for a long period of time, possible that you can have the alcoholic fatty liver. Second, alcoholic hepatitis. Alcoholic hepatitis presents with common signs and symptoms, including nagkakaroon na ng liver, okay, ascites, proximal muscle loss, and far more laboratory evidence of liver damage, such as moderated elevated AST, okay, tumataas yung AST, tumataas ang ALT, even for GGT or the gamma-glutamyl transferase, and tumataas din ang alkaline phosphatase. Okay? So, 4 yun. Mataas ang AST, ALT, GGT, and alkaline phosphatase. Even for the total bilirubin. The total bilirubin is greater than 5 mg per DL. Okay? So, the elevations in EST are more than twice. Okay? The elevation in EST are more than twice the upper reference of normal but rarely exceed 300 international units per ml. But the elevation in ELT are comparatively lower than the EST, resulting to an EST-ELT ratio greater than 1. Because normally, guys, normally, yung EST to ELT ratio natin, hindi dapat yan tumataas ng 2. Okay? Kasi, mas mababa si ELT dapat kaysa kay mas mababa si EST as compared kay EST. Okay? So, in a normal individual without alcoholic hepatitis. However, the serum proteins for alcoholic hepatitis ay bumababa. So, si albumin ay bumababa. Okay? In alcoholic hepatitis. Bakit bumababa yung albumin? Take note, guys, that proteins except immunoglobulin, adult hemoglobin, and von Willebrand factor are made in the liver. So if the liver is not functioning well, it cannot synthesize well the serum proteins. So last, alcoholic cirrhosis is the most severe with a poor prognosis. Okay, so the prognosis associated with alcoholic cirrhosis is dependent on the nature and severity of associated conditions such as gastrointestinal bleeding or ascites. However, 5-year survival is 60% in those who abstain from the alcohol and 30% in those who continue to drink. And the condition is more common in males than in females. And the symptoms tend to be nonspecific, which includes weight loss, weakness, hepatomegaly, so increase in size of the liver, splenomegaly, increase in the size of the spleen, jaundice, okay, yellow coloration of the skin, mucous membrane, fever, increase in the temperature, malnutrition, and edema. Okay, so that's the end. That's the end of our discussion. End na talaga yan. I just forgot the last slide. So, I wish you well, guys, and I hope that you study well. Okay, despite our situation now, you are already in the comfort of your home. So, I hope na mas makapag-aral kayo ng maigi. Okay? Unless, since you are in the comfort of your own home, baka tulog naman kayo ng tulog. But please, guys, you had already a long period of time para matulog, para manood. So, I hope you focus on your studies and huwag kayong magsasawa sa mala-DJ kong boses. Char. Okay, huwag kayong magsasawa because I am your teacher for parasitology and clinical chemistry too. And even if it's a lot harder, ang hirap mag-record, mas gusto ko pang magklase na lang tayo. Even if it is a lot harder than giving you modules, okay? Magtsatsaga akong mag-record. So please lang, pakinggan nyo din naman. And yun lang, para ma-check ko na nakikinig kayo, mostly ng quiz nyo ay nasa discussion natin. Okay? So, hindi lang siya galing dito sa PowerPoint, but from the discussion, and I'll ask you to explain kung bakit mataas, bakit mababa. Okay? So, I wish you everyone a good health, not only physically, but mentally, emotionally, and spiritually. Okay? Magiging RMT din kayo soon. So, please lang, mag-aral kayong maigi. So, God bless everyone.